So for eosinophilic esophagitis, you know, it's been a big year. A lot of things have happened. There have been a lot of publications, advancements in the science, in the basic science of eosinophil biology and eosinophilic esophagitis. Lots of patients are being correctly diagnosed and diagnosed more early. And for me personally, it's been a big year because I got married last year. That's not my wife. That's my wife. Anyway. So eosinophilic esophagitis, you know, is a relative newcomer to the world of pediatric GI. Eosinophils obviously have been around for a much longer period than that. In the medical literature prior to 1982 or so, eosinophilic esophagitis was mostly a diagnosis made by radiologists by X-ray. I'm not sure exactly how they did that, but that's how it shows up in the literature. And then in 1982, there was a publication from Harvard that suggested that eosinophils in the esophagus were a clear marker of reflux disease, and for a very long time, it was assumed that that was the case, and that if you saw an eosinophil in the esophagus, it meant that the patient had reflux disease, and that was the end of the story. But then in 1995, the first real pediatric report that made a distinction between reflux disease and eosinophilic esophagitis was published by Kevin Kelly and the group on the East Coast that showed that eosinophils that don't respond to conventional anti-reflux therapy might be responsive to an elemental diet, which launched what I think is really the modern era of recognition of eosinophilic esophagitis as a separate disorder. So that was 1995. It took a very long time for the world of pediatric GI and adult GI to come to consensus about diagnostic criteria. But this report that was published by a number of us in the journal Gastroenterology was the first major consensus statement that put together the clinical features, the endoscopic features, and a set of diagnostic criteria that people could follow, so that we made things more standardized and easier for people to recognize around the country and around the world what eosinophilic esophagitis is. So as you heard from Dr. Markowitz, the disorder itself is what's referred to as a clinical pathologic disorder. It means that there are clinical features and histologic features. Histology refers to what it looks like under the microscope. The clinical features of eosinophilic disease we're going to go through over several slides, but in general they're nonspecific and mimic symptoms from other esophageal inflammatory disorders. But by definition, as we've said, it's not reflux, and therefore it doesn't respond to therapy for reflux. And under the microscope, as you've seen, the inflammation that's there is eosinophil predominant mucosal inflammation. So the clinical features that we'll go through over the next several slides include the symptoms. And I like to separate the symptoms into three categories: pain, vomiting, and dysphagia. Pain is very difficult for some younger children to describe and may manifest just as irritability. But as kids get older and more effective communicators and become more effective communicators, they can describe what they feel. And sore throat is a very common complaint, as is pain just above the belly button. Sort of doesn't make any sense that a child would say that their stomach hurts when their esophagus is in the chest, but it's very common for abdominal pain rather than chest pain to be the reported symptom. Heartburn is certainly possible. Substernal pressure, the sensation of cramp in the chest, is sometimes what people describe, although that's not as common as just a more nonspecific description of pain. Vomiting is problematic and probably gets kids to medical attention sooner than other symptoms, but is really quite variable in this disease. It tends to occur mostly in the younger population, infants and toddlers and younger kids, but it can occur even later than that. It's really quite variable in how it presents. Sometimes it seems completely random, not associated with anything that you can predictably expect. Sometimes it's directly related to meals. Sometimes it's directly related to the ingestion of a particular food, and every time that food is eaten, vomiting is the result. Sometimes it's sort of a reflex mechanism that's induced by coughing. Some people have what's called post-tussive emesis, where they get into a coughing fit, which stimulates their gag reflex, and then they vomit. It's not really gastrointestinal disease at that point, but it's still vomit. I think the vomiting in eosinophilic disease is more of a true vomit, which is different from effortless regurgitation. Effortless regurgitation is what infants do when they reflux or something just appears in their mouth, and they may swallow it back down or it may come out. Vomiting, on the other hand, is the sequence of events that's a patterned physiologic event with gagging and retching and then forceful expulsion of your gastric contents. As Dr. Markowitz noted, dysphagia is a very common symptom in eosinophilic esophagitis, and dysphagia refers to, in a broad way, the sensation of difficult swallowing. It's again difficult to get very young children to precisely describe what happens when they swallow something, and it may be manifest solely as episodes of gagging or choking in young babies or toddlers. As kids get older and they're more able to communicate, they start to describe the sensation of food going down slow. It may get stuck, it may hang up temporarily and then proceed down the esophagus. It may get stuck enough that they have to kind of choke it back up or throw it back up. And sometimes it gets overtly stuck, which is what the picture shows, a piece of chicken stuck in the esophagus that had to be removed by endoscopy. Those aren't very common, but they do occur, and sometimes they're the very first appearance of the child to medical attention for the trouble that they've had swallowing for a long time. These are data from a study that Dr. Noel did when he was a fellow in Cincinnati a few years ago, and I like to show this slide because to me it sort of shows the symptoms of eosinophilic esophagitis as they vary by age. And it's important to recognize that young babies with eosinophilic esophagitis are not likely to present with a food impaction. But feeding disorders, gagging, choking, food refusal, irritability around feedings is the more common means for a young child to present with this disorder. Vomiting, as I said before, tends to occur a little bit later, but certainly does happen in infants as well. And then as the kids get older, their complaints of abdominal pain increase, and the complaints of difficulty swallowing or dysphagia start to occur a little bit later in school age and then certainly on into adolescence and adulthood. In adulthood, the predominant symptom is clearly difficulty swallowing. I think it's important to recognize that the data that were used to create this slide are cross-sectional data. It means that at one point in time, patients were looked at for the symptoms that they had. This doesn't mean that a young baby who starts out with a feeding disorder who isn't treated with eosinophilic esophagitis will necessarily progress through these symptoms as phases over time. But in a cross-sectional way, it does show what we see. I think it's important to recognize that children with eosinophilic esophagitis have other conditions, asthma and allergies, environmental allergies, chronic rhinitis, runny nose, and you'll hear more about the allergic features of eosinophilic disease in a later talk, but it's important to recognize that because these patients have other conditions, they have symptoms associated with the other conditions. So they may have cough or sore throat as a result of asthma or their chronic postnasal drip. We do have patients who present to us with recurrent croup, infections of the airway that cause a barky cough, and then obviously the other allergic symptoms that people get. These aren't directly related to the esophageal disease, but they're associated symptoms that the patient may have. So as physicians, we have to be careful in making a good judgment in deciding which symptoms are coming from the esophagus directly and which are just associated symptoms that the patient may have related to their other conditions. And it's also important, I think, for everybody to remember that all of the symptoms of eosinophilic esophagitis are nonspecific. It means that there are other diseases that have exactly the same symptoms, but not eosinophilic esophagitis. It's also important to remember that there is a very poor correlation often between the symptoms that somebody describes and what their biopsies look like and what kind of esophagitis they have. So you have to be very careful about interpreting both the presence of symptoms and the absence of symptoms, and use the biopsies as a better judge of the state of the esophagitis. So part of my charge this morning is to talk about how we make the diagnosis of eosinophilic esophagitis. And I'm going to take you through a variety of ways of thinking about this, as well as just the practical nuts and bolts of how we do that. And I think as a concept, it's very important to keep in mind that there's two kinds of diagnoses that are made. There's a histologic diagnosis, which is what the pathologist writes on the pathology report after they've looked at the slides. And then there's the clinical diagnosis. The clinical diagnosis is what I tell you you have after I've taken into account the symptoms, what it looks like under the microscope, and all the other features of the symptom complex that your child may have. So when we talk about a histologic diagnosis, that's 15 eosinophils per high-powered field. But that doesn't make a diagnosis of eosinophilic esophagitis as a clinical diagnosis necessarily. So it is correct that our current consensus statement recommends the use of 15 eosinophils per high-powered field for the pathologist to be able to start referring to it as eosinophilic esophagitis. It does, as Dr. Markowitz said, require that multiple biopsies be taken from the esophagus because the disease can be quite patchy, and if you don't take enough biopsies, you may miss it. But it's also true that to make the correct clinical diagnosis, you need to know what caused the eosinophils to come to the esophagus, because there can be eosinophils in the esophagus in other diseases. And this is a list of other kinds of esophagitis that we see. The word esophagitis just means inflammation of the esophagus, and you need an adjective in front of that to decide which kind of esophagitis you're talking about. You do get inflammation in the esophagus from certain infections. Candida, which is a yeast, can live on the surface of the esophagus and cause inflammation there. There are viral esophagitis. Most common is herpes. Obviously, the most common chronic cause of esophagitis is from acid injury from reflux. And reflux esophagitis also has eosinophils in it. We do see in young children inflammation of the esophagus as a result of a caustic ingestion. A small child who drinks something from a bottle that they shouldn't, cleaning compounds or Drano or those sorts of things that cause injury to the esophagus. But there are also some pills that cause esophagitis if they hang up in the esophagus and don't go all the way down. The local injury to the esophagus where the pill dissolved is called pill-induced esophagitis. And it's very painful, but it's a very localized thing and transient. Then obviously there's eosinophilic esophagitis. But there's also esophageal involvement with other chronic inflammatory bowel disorders. You heard that even with eosinophilic gastroenteritis, there can be esophageal involvement. We see eosinophils in the esophagus in patients who have Crohn's disease and also celiac disease. So just the pathologist identifying eosinophils in the esophagus under the microscope isn't sufficient for them, for me to tell you that you have eosinophilic esophagitis. So the clinical diagnosis then requires that you have the biopsy findings. If you don't have the biopsy findings, you don't have the disease. But then you have to have the objective absence of some other condition that could mimic that. And reflux is the most common one. But then we have to rule out celiac disease or Crohn's disease, other drugs that you may be taking, and eosinophilic gastroenteritis. So again, the histologic diagnosis is not necessarily the same as the clinical diagnosis. If the biopsy is positive for eosinophils, then you have to decide which disease is it. And if it's eosinophilic esophagitis, then it's up to me to help sort out which kind of eosinophilic esophagitis. You know, we talk at these meetings as if eosinophilic esophagitis is one disease, but I think it's a mistake to think that because there are multiple different subtypes of eosinophilic esophagitis, patients who fall into categories of similarity in the way they act, the way their disease responds to therapy, and et cetera. So I refer to this as phenotype discrimination. How do you distinguish what kind of eosinophilic esophagitis you have? So on the one hand, it could be reflux. There are patients who have all of the findings of eosinophilic esophagitis under the microscope that is induced by acid injury from reflux. And we sort that out by treating the patients with a proton pump inhibitor to manage their acid production, or by doing a test to see if they have reflux disease, which nowadays is mostly done by multi-channel intraluminal impedance testing, which is superior to pH testing alone. But then there are other patients who have real deal eosinophilic esophagitis, which you all know. And then we have to decide, okay, if it's really eosinophilic esophagitis and not reflux, which type of eosinophilic esophagitis is? Is it the allergic form? And you'll hear more about that later. The allergic form, in my view, is that form which is responsive to dietary antigen elimination, and it comes back when the offending foods are put back in the diet. But there is seemingly a so-called non-allergic form, which doesn't seem to have an obvious food or other environmental allergic trigger, and doesn't respond at all to any degree of dietary elimination, up to and including the use of an elemental diet. Is it some other GI disease? Is it Crohn's disease? Is it celiac disease? Is it eosinophilic gastroenteritis? And as Dr. Markowitz said, the discrimination of those is really fairly simple, because at the time of endoscopy, we're biopsying the stomach and small intestine, which allows us to determine whether there's evidence for any other inflammatory condition that could be present. Unfortunately, there's also a group of patients who have both reflux and eosinophilic esophagitis. They have clinically relevant reflux that requires the use of ongoing treatment for that, and dietary management or some other form of treatment of eosinophilic esophagitis. So it does get a little bit complicated, and a good number of patients are on therapy for reflux as well as their eosinophilic esophagitis. Unfortunately, we don't have a way of discriminating the phenotype when you walk in the door. We learn the phenotype from a review of the clinical and biopsy information and how the disease responds to various therapies over time. So now I'm going to move on a little bit and talk a little bit about the things that have happened in the research world that may ultimately help make a diagnosis of eosinophilic esophagitis, although they're not available at the moment. So one of the questions that comes up is, what factors promote the development of eosinophilic esophagitis in a particular family or a particular individual? Is there genetic susceptibility that would account for the familial occurrence of this? And that raises the question, are there specific genes then that are abnormal in eosinophilic esophagitis? And ultimately, can we make a prediction about the likelihood of a disease using genetic testing? The short answer to that is no, but there's a longer answer that's worth talking about. For folks who haven't had high school biology in a while, it's probably worth spending a couple of slides just doing a little bit of review of what genetics really are, so that we're all sort of talking about the same thing. All cells have the same DNA, and therefore the same genes. The chromosomes inside a cell are made up of DNA, which is folded up, but if you unfold it and unravel it, it contains the code for every protein that's made in the body. Each gene has the genetic code for a particular protein, and inside every cell, the genes that are needed for that cell to function as itself are turned on during development. So skin cells have genes that are turned on to make them have skin proteins, and muscle cells make muscle protein, but skin cells don't make muscle protein because the genes for that aren't turned on. So it's a very complicated process during fetal development to turn the right genes on and turn the right genes off so that every cell does exactly what it's supposed to when it's supposed to. But it's also possible to turn some genes on later when they're needed by the cell. So when genes are abnormal, thank you, there are a variety of different ways in which they can be abnormal. On the one hand, they may have the wrong code, so that the protein that's produced isn't functional, just doesn't work. Or it may actually not make the protein at all. But it's also true that you may not have the right signal to turn a gene on at the appropriate time when it needs to be turned on, so that a protein isn't made when it's needed by the cell, or it isn't made when it should be. This is a diagram that I've showed before that requires a little bit of description so you understand what you're looking at. This is the result of what's called a genetic microarray. And if you look at across the bottom, there are individual patients labeled by number. So each vertical column is one patient. Each horizontal row is a gene. And the color indicates whether the gene is at its normal level within the cell, turned on, which is red, or turned off, which is blue. There are 3 groups of patients in this slide. The first 6 are normal individuals, and you can see that the majority of their genes are yellow, which is at their usual state. In the patients 7 through 11 have reflux esophagitis, and if you look carefully near the top, there are some genes in red that are turned on, and some genes in blue that are turned off, and that's the characteristic pattern of reflux esophagitis. And then the patients 12 through 24 have a very obvious common set of genes that are turned on in red and turned off in blue. And then there's some overlap near the top where there's some genes that are turned on in eosinophilic esophagitis just like they are in reflux. So this is a very complicated set of genetic information, but it provides us with the targets to shoot at, if you will. These are the genes that are active in eosinophilic esophagitis on the one hand in red, or turned off in blue. And maybe they shouldn't be turned off in that set of blue genes. But, you know, when you're talking about thousands of genes, things get really complicated. This is a diagram that has nothing to do with the slide that I showed you before, but this is how complicated the interactions can be. I'm going to give you about 30 seconds to look at this. There will be a quiz at the end. But the point is that eosinophilic esophagitis has a distinct pattern of genes that are turned on, which are upregulated, turned off, which are downregulated, and that may offer ultimately a way to make a diagnosis. If we took a biopsy and applied gene chip technology to that tissue, maybe we could identify by the pattern of genes that are turned on and turned off whether you have eosinophilic esophagitis or reflux or something else. At the moment, that's not commercially available, not clinically available, but it's still in the back of our minds that that may be an option in the future. And then there's a second question. The second question is there a gene, one gene that's passed from generation to generation that produces the signal that turns all those genes on and off that makes eosinophilic esophagitis happen in a family? The short answer to that is no. There's not going to be a single gene that's responsible for this. But you heard yesterday that there has been a study that showed an association between a particular gene and eosinophilic esophagitis. This was a genome-wide association study, so a statistical analysis of what genes are associated with active eosinophilic inflammation. So population study, not a biopsy study anymore. The genes that are turned on and turned off we were looking at in tissue. This is now the genetic abnormality that might account for susceptibility to eosinophilic esophagitis. So the gene that was statistically associated was at a location called 5q22.1. That means it's on the 5th chromosome on the long arm at position 22. It's the gene for a protein called thymic stromal lymphopoietin, which is made by epithelial cells. Epithelium is the surface lining. And it is known to participate in producing an allergic phenotype. And its receptor, which is a complicated process of interaction with between the TSLP and its where it attaches to the cell is on a different chromosome, and may account for, which is one of the sex chromosomes, so it may account for the male predominance of this. So what's important to recognize is that this is not the gene that causes eosinophilic esophagitis. This is a gene that is statistically associated and may well promote susceptibility to the development of eosinophilic esophagitis, but by itself is not going to be the cause of eosinophilic disease. And the statistical studies that are done don't prove causality. It doesn't prove the cause of eosinophilic esophagitis is related to this. That requires taking this protein back to the lab, sorting out what role it really plays in producing inflammation, turning genes on or turning genes off, or creating the signal that calls eosinophils to the esophagus. That's years worth of work to accomplish, but that's what's happening in the background. That's what we need to know about this disease. I think I've said this stuff as we've gone through this. The genes that have been identified to date are susceptibility genes. They're candidates for additional study, and they're not the genetic cause for eosinophilic esophagitis. Eosinophilic disease is going to turn out to be and is a complex inflammatory disease that's not going to be a result of a single abnormal gene. So for the future, we want to take what's already been learned and go forward. With your help and your children's help, by participating in the research studies that are being done in San Diego and Denver and Philadelphia and Cincinnati and Greenville, we will ultimately learn much more about this disease and the very basic underpinnings of it, so that we can make an easier diagnosis, maybe without endoscopy someday, and help you identify the phenotype so that you're treated correctly at presentation rather than after you've already failed several attempts at treatment. I appreciate your attention, and there will be questions later.